Hi, good evening, everybody. I'm Dr. John Santana.
Dr. Tom Nabity.
We're coming from the Michigan Center for Regenerative Medicine here in Rochester, Michigan. And we wanted to dedicate this evening to have a discussion about back pain.
And it's going to be a relatively broad topic. We're going to try to cover a lot of different material tonight. We hope that you guys can have some questions and feel free to type those in. We have a moderator assisting us, so we'll be able to do some question and answers at the end. So as we're talking, if you think of things that you'd like us to elaborate more on, please do type those in, and we'd be happy to answer those at the end. So I guess kind of just jumping right into it. If we're assessing a patient, Dr. Santana, if you're assessing a patient coming in with low back pain as their primary pain complaint, what sort of questions you want to know, what sort of history sort of things are important to you?
Yeah, so when a patient comes in, typically I want to know, how long have they had this pain for? Is it something that's fairly new, like you were just kind of horsing around the weekend and then you hurt yourself? Or is it something that's been kind of brewing for a long time and just over wear and tear has had an issue? Or you've had an injury, a few months ago or a few years ago, and now it's just this lingering pain, it just won't go away. So just help us kind of figure out whether this is an acute pain, that's something that's fairly recent, that's within 3 months, or is it more chronic, where it's greater than 3 months and it's been longer. So the chronic pain aspect is what we'll probably concentrate more here, because that's the pain that's really irritating and more problematic because it affects a whole aspects of your life.
Yeah, most people with acute pain, they're able to get to their chiropractor, their primary care doctor, or get some physical therapy, and most of those don't end up making it to us in our office, fortunately. But those that do have the chronic pain that's been lasting 2, 3, 4, 6 years, 6 months to years, what kind of thoughts and specific historical things are important to know?
Yeah, so it's nice to know like whether this was what started the injury, right? Was this from an injury, or is this from a wear and tear type issue that's been ongoing and progressive, or is this something that's kind of came on all of a sudden, or so just being able to figure out exactly what the source of the pain is or how it started helps us figure out how to tailor the treatment directly to you. Other areas that we want to look for is what precipitates the pain. Is this pain there all the time, or only when you do certain things? So that would also help us kind of figure out where it is. Also, the quality of the pain. Is it like a sharp pain? Is it a dull pain? Is it more of a pins and needles electrical pain? Does it shoot down your leg? Does it wrap around your abdomen? So those kinds of qualities of the pain that you want to know about too. What are the things that would you?
Yeah, no, I think you hammered home on the historical features. A lot of times people will come in with diagnostics as well, which is helpful. If not, oftentimes we'll order them. Diagnostics include things like x-rays or CAT scans or MRIs. And those are things that when used in conjunction with their history and their physical exam sort of features that we'll look for, really help us try to pinpoint what we think is causing the pain. Not all abnormalities seen on a diagnostic image, like an MRI in particular, necessarily mean that that's the problem. Just because something looks abnormal doesn't always necessarily mean it's the source of the pain. But when put in context with things like their physical exam, do they have pain when they raise their leg? Do they have pain when you have them bend backwards and twist side to side? When you push on specific areas of their body, do they have reflex abnormalities? Do they have sensory abnormalities? Those are all the things that we're taught as physiatrists and spine pain specialists to try to really hammer home on what we think the source of your pain is, what we think the number one thing causing your pain is. And then, as being interventional pain physicians, oftentimes we want to try to further diagnose that and know specifically that's causing your pain by doing some sort of an interventional procedure.
Yep. Just going to harp on the point about MRIs and stuff like that. MRI is a really fantastic tool that we have as physicians, but at the same time, it's a double-edged sword because it's a very involved study that will be able to see a lot of things in really good detail. And whether those things that you see in the MRI is pertinent or it affects you clinically is a big determinant factor that we have to figure out. And I think that's where the experience of having physicians who've been doing this for a long time, and I've seen a lot of patients and I've helped a lot of patients being able to sort out which is your real source of the pain and actually diagnose it correctly so that we can treat it appropriately. And so with that point, so yeah, there's some interventional procedures that we do that helps us pinpoint the source of the pain. So when we do these injections and these procedures, it does two purposes. One is it helps us, find the source of the pain, and the other thing too is helps us address the pain. So it kind of helps confirms what we're already thinking as far as your differential diagnosis. So one of the most common type of spinal injections we do is something called an epidural injection. So an epidural injection is an injection that we do under X-ray or a fluoroscopy, where we would put the needle directly in the area in your spinal canal and put a combination of an anesthetic and a steroid in that area to see if we can reduce a lot of the inflammation that's happening in there. Typically for somebody who has back pain with a component of a shooting pain down the leg, it would be a good candidate to try an epidural injection.
Yep, and be extremely helpful. And I've certainly seen cases where it's a one shot and done. Their pain goes away. They're compliant with their exercise, and unfortunately, that those patients don't come back and see us. But we do have a lot of patients where they work, but they only provide some temporary relief, and that temporary relief can be days, it could be weeks, it could be months. There is a limit to how many steroid injections I'm comfortable giving. There's certainly a limit to how many insurances are willing to pay for, where you start wondering if you're doing damage. Where I'm at personally in my practice now, I don't think a single steroid shot or a set or even two or even up to 3 steroid shots is going to degenerate your discs or is going to lead to dissolving of structures in your spine. I don't think there's toxicity specifically to the medicines, but these medicines are pain relievers. And if you're not really fixing the problem and you're masking the pain with medication, that potentially can allow patients to do more damage that they would otherwise feel, and pain would stop them. And by taking that pain away, we're allowing them to do activities that maybe continue to develop pain. So how I like to incorporate these pain injections is really to help you get over that maybe roadblock that you're having in your physical therapy or that impediment you have to making progress with your exercise or your diet, losing weight. All those things are extremely important to getting a good long-term outcome. These injections aren't meant to be a cure that just masks the pain forever. It's meant to give you a temporary window to allow you to change certain aspects in your life that are leading to this pain, or to give your body time to heal rather than just suffering with pain for a long period of time while your body's trying to heal this disc herniation or this pinched nerve or whatever the source of that pain is that we're treating with an epidural. We're able to make that time not be so painful while your body's healing itself.
Yep. And again, it also helps us kind of pinpoint exactly and make sure that that's really the source of the pain. Right? So the other type of injections that we would do would be something called a Facet Block or a medial branch block. So the idea with that injection is if your pain primarily has characteristics where it's primarily in the lower part of the back, it's non-radiating, usually affected with activities or range of motion, things like that. That usually would lead to believe that your back pain is related to mostly arthritis or degenerative type changes. So for this type of a diagnosis, the treatment I would recommend would be something called a Facet Block or a medial branch block. With the idea is in your spine, you have these bones stacked one on top of the other, and they're making contact with each other. So like any other joint in your body, once that contact between those two bones start to wear down and that space starts to wear down, that's when you start getting arthritic pain in that lower part of the back. So with this procedure, what we're able to do is actually inject right in the area of that joint, or at least to the nerve that gives tissue to that joint. And it serves two functions. One, it helps us identify the main source of your pain. And the second thing, it also is curable. I mean, it helps block that issue so that you can't go back to your normal activities. The next step to that, if we're able to show that by blocking these nerves and by treating your facet pain with a facet injection, the next step that we could do is something called the radio frequency ablation. So The radiofrequency ablation essentially follows the same pattern that we did with the blocks, but instead of just injecting an anesthetic or a steroid that's temporary, we can put a small probe by the nerve that gives you that sensation of pain in your lower back and essentially stuns the nerve, or some people call it burns off the nerve. And that typically gives you relief for around 8 months to a year. So a lot of time for you to be able to do physical therapy, to make some life changes with your diet, to lose some weight, start exercising more. And hopefully, as the ablation wears out in 8 months to a year, it's going to be a totally different environment, totally different back that it's trying to address.
You do have a spine model here that kind of can demonstrate some of what we're talking about. So when we're talking about like a pinched nerve, you're looking at between the two bones, there's a disc that can irritate and pinch that nerve. And then the other joints that we were just discussing are these joints back here called the facet joints, which are not disc joints, they're finger-like joints. So just like the synovial joints between our finger bones, it's the same type of joint in your spine. And then just a little more elaboration on that radial frequency ablation procedure. I use an ink pen because I think it makes a lot of sense, but we're essentially using a needle that we place into the spine, very specific locations where the nerve runs. And then instead of just injecting medicine, we stick that probe that Dr. Santana was mentioning, which sticks out the tip of the pen, just like an ink pen there. And this type of needle is called a cannula. It's all insulated, so none of the needle will heat up, and only the tip of the needle where the wire sticks out heats up, and it's able to ablate that nerve, which I equate these nerves being kind of like electric wires with a plastic coating on the outside. That coating is something called myelin, and the ablation procedure strips that plastic coating off. And when you do that, the nerve doesn't function anymore, so it can't transmit pain. It takes about 6 months to 2 years, so somewhere in that 8 month to year and a half timeline that Dr. Santana mentioned, for that nerve to remyelinate or recoat the nerve with plastic. And then the nerve functions again, and hopefully you've changed your biomechanics, you've made some sort of other changes in your life so that when that nerve starts firing on all cylinders again, the pain doesn't come back.
Yeah.
So another major source of spine pain can be a joint called the Sacroiliac Joint. That's a joint that connects your spine to your pelvis. It's just located just off to the side of your hip bones. I describe it being the other hip joint, not the ball and socket, but the hip joint that's on the back side of it. And what's very difficult and challenging about our jobs is all these pain sources oftentimes sound the same in their history, and even their exam findings can have a lot of overlap. So,
and over time, like they start kind of just mimicking each other, so that kind of makes these a little more difficult.
One problem melds into another problem. Your body has a way of compensating. Hey, you had a disc problem for 10 years and kind of just been dealing with it, and your body has been trying to absorb that force, and it puts it above and below, which you can put it on the SI joint or the facet joints. And it does make our job fun, but challenging. And this is where diagnostic injections really come in. So that's an SI joint is one where we're commonly putting, just like we do the facet joints in the spine, where we'll do a very specific injection using an X-ray or ultrasound machine, where we can very specifically know that our medicine is only spreading into the SI joint, and have you hop up off the table and re-examine you and have you move around, and either your pain got a lot better or it didn't. And that helps us from a diagnostic standpoint, because then we can really go down a therapy on a specific pain generator.
And the thing about the SI joints too is that we usually call that like the great mimicker, right? Because it kind of shows like all kinds of issues with the back pain. But Dr. Nabity's right. It's usually doing an injection kind of does help pinpoint. But over time, more often than not, it's not just one unifying source of pain, right? It's usually a combination of all these other things over time that kind of adds on. And for those types of things, we have to come up with a really good comprehensive plan, with not just interventions and injections, but also with lifestyle changes, physical therapy, things like that.
So maybe now would be a good time to talk a little bit about how we are incorporating regenerative medicine into some of these treatments, rather than just simply masking the pain with medications and cortisones. If we are doing these procedures and the pain keeps coming back, Oftentimes the next therapy is to send to a surgeon. Let's surgically cut out tissues, or let's surgically pin two bones together, something called a fusion. But rather than those options, we are focusing on biomechanics, the things that are leading towards the degeneration of the disc and the degeneration of the facet joints, or the laxity and the movement that's happening at the SI joint. Maybe turn over to you to comment a little bit more about how regenerative medicine can help.
Yeah, so the way that we look at things with regenerative medicine sense is that we know that everything in your body acts as a unit. So your body has this wonderful capability to compensate for injuries and other things. But over time, sometimes overcompensation can lead to injuries and wear down in some other parts. So with regenerative medicine, we want to look at the entire structure. And the idea with regenerative medicine is that your body's always in this state of degeneration where it breaks down old tissue and it replaces it with newer tissue, which is regeneration. With injuries, with trauma, wear and tear, old age, the rate that your body degenerates supersedes the rate that your body can regenerate tissue. So what we do with regenerative medicine is that we're using your body's own healing mechanism that we know that you have, concentrating it in a solution and injecting it directly into the areas that we need to address. So in terms of back pain, if it's a facet-mediated pain or something along those lines, then we would inject into your facet joint to try and rebuild that joint space. If it's more a discogenic issue where the disc itself is the problem, then we can also inject into the disc to try and help stop the degeneration of the disc and also to hopefully get it back to its normal state. And on top of that, we also treat a lot of the ligaments and the tendons in your back. Because if you look at this model, it's your spine is a pretty complicated structure. There's a lot of ligaments kind of holding all these bones together. There's a lot of muscles and tendons that's kind of holding all these structures together. And the more stable your back is, the less pain and less prone to injury it is. But unfortunately, with wear and tear and injuries, the back does become more unstable. And a lot of these ligaments need to be reinforced in order to get that stability back.
So I'll piggyback on that comment. The injection techniques we use as pain management physicians, where we're blocking the pain, while the skill is the same, using ultrasound or x-ray to see a target and very specifically drive a needle or some sort of a injection device towards a very specific target. When we have our pain management block the pain hat on, we want to find very, very limited numbers of targets to hit, because we want to know what pain's coming from what source. When we put our regenerative medicine hat on, it's more of a global injection technique where we want to hit all the structures that are involved in stabilizing what our pain generator is. So, what do I mean by that? There's a term called biotensegrity that is more of a engineering term, where things are held in terms by, are held in place rather by cables. So when we're taught about the skeleton in our human bodies, we're always told, or at least I was, growing up in Nebraska, maybe it's a Nebraska thing, but that the bones are the foundation of our body. It's what our whole body is held in place by. Well, if you take that concept with a building, you can strip the 2x4s and the drywall away, and the foundation of that building doesn't move. Well, what happens when you take the ligaments and the muscles and the connective tissues that are holding our bones together away? Our skeleton falls apart. It falls apart into a pile of bones on the floor. It's not inherently stable. It's held in place by all these connective tissues, these ligaments, these tendons. So think of them like tight rubber bands holding things in place. And those rubber bands are what's taking pressure off of certain areas. So when you have a disc herniation, for example, the spine is a bit like a tripod. Okay, you have 2 points of attachment in the back, and you got 1 point attachment in the front. Well, if we're trying to take pressure off that disc from the front, by injecting these structures in the back, we're able to tighten those ligaments up, and it takes pressure off the disc. So long story short, our injection techniques for when we're going for regenerative medicine is really to treat all of those structures that are involved in stabilizing the spine or stabilizing the SI joint or whatever our target is, in order to regenerate and tighten up those ligaments, tighten up those rubber bands that are holding things in place.
So it's very successful. A lot of our patients who have tried and failed a lot of procedures and injections and stuff like that do respond to regenerative medicine, because as long as your body's still able to regenerate and heal, then it's still going to be effective. The biggest downside to regenerative medicine right now, it's still not covered by insurance. So that's why me and Dr. Nabity and everyone here at the Michigan Center for Regenerative Medicine, we offer all these options for patients. So the insurance-based procedures that's going to be covered by your insurance, and procedures that's a little bit more outside the box that's not covered by insurance, but at least you have all the options that you have. And you know, let's have to say too that sometimes there are just some things that we can't fix, and that's when we rely on our neurosurgical colleagues and orthopedic colleagues. So sometimes if the injury or the degeneration is too advanced, then usually surgical options are going to be the best option there.
So we do I think a very good job of being comprehensive in our treatment approaches. Number one, find the pain generator, figure out the diagnosis, and then walk you through the the continuum of care options, starting with the least invasive, least risky stuff first. Typically, what your insurance covers first, and then walking that road, and at least bringing up the stuff that has merit. There's very good studies out that show that regenerative medicine is a legitimate option for specific types of conditions, and at least laying those options out for you before pursuing a surgical management. If, let's say, you did have surgery and we unfortunately weren't able to get you good pain relief with the conventional treatments, the regenerative medicine treatments, you went on to surgery, and now you still have pain. Unfortunately, that does happen, especially when you were talking about spinal conditions and spinal pains. All isn't lost. There are still more options that we have to talk about, and Dr. Santana, what kind of things would you think about for that sort of patient?
Yeah, so for post-procedure pain, post-surgical pain, one of the best tools that we have for treating that would be a spinal cord stimulator. I do like this treatment because it kind of goes by the same principle of trying to do a minimal thing, but that's going to be very effective, right? So with a spinal cord stimulator, the way that it works is you're in your spinal canal, in your spinal cord, the way that your nerves transmit pain signals is through electrical impulses. So what a spinal cord stimulator does, it's a procedure that we do here in the office. It's a small injection procedure. There's no incisions to it, but what we do is we insert a very thin piece of wire right onto the epidural space in your spine. And what this lead does, it blocks and modulates all of these pain signals and these electrical impulses that your nerves are transmitting to let you know that you have pain. So by modulating those pain signals, we're able to block and control your pain in real time and quickly, and we can tailor it to exactly where your pain is coming from, whether it's just a small part of your leg or your entire leg or both legs or everything from the waist down. We're able to tailor that exactly for your pain. And it comes with a handheld where you can turn it up or turn it down depending on your activity level and how much pain relief you need.
Yeah, so how can one device cover all of those areas of your body? If you think about our nerves being like little roads, and all those roads feed into a super highway that then finds its way up to your brain, you perceive everything that's happening in this world by signals that are getting to your brain. So if we can shut that super freeway down, which is essentially what we're doing with these spinal cord stimulators. So the other term for them are called dorsal column stimulators, because they go right over the dorsal column in our spinal cord. They don't go in the spinal fluid, they go outside the spinal fluid in the epidural space, which is a very safe place to access. It's where we do our epidural injections when we're doing steroid and lidocaine injections. And these devices, we saw a picture a couple screens back, have these little electrodes on them. So I like this picture here. You can see all the different types. They have wide spaced electrodes, narrow spaced electrodes. And then if you look in the background here, you can see the picture of kind of some green dots and some purple dots. That's the technology at work where we're able to drive small amounts of electricity in certain areas, larger amounts of electricity other areas. We're able to increase what's called the pulse width or the amplitude, which is essentially, if we're thinking about this being your spinal canal and this being the electricity, and the electricity is touching your spinal canal, we can increase the amplitude, or we can, slap it harder, or we can go down the amplitude, but we can go way up on the frequency, and we can slap it really, really quick to the point where, my hands are touching each other, and they're going back and forth so fast that you just don't even perceive it. Something called sub-threshold therapy. There are, long story short, lots of different options with these devices where we can use the tricks within that are within the algorithm and the ability that these batteries and devices have to block your nerves.
Yeah.
And the end result is that freeway gets shut down, your pain is relieved, and you're able to get back to the things that you enjoy doing.
Yeah. But Dr. Nabi, do I have to have surgery before I get a spinal cord stimulator?
Great question. So the answer is no. It's not just for people who have failed surgery. It is an alternative to surgery for specific conditions. And it just depends on what surgical option we're talking about. So if you have a small disc herniation that's very amenable to a lumbar discectomy, I'm going to probably convince you that lumbar discectomy is best for you. Get a one-time surgery. It's very low risk, and you won't have to have a device that's simply masking the pain, because that's what we're doing now. We're not masking with medicines. We're masking with electricity. So still trying to fix the problem rather than just mask the pain. Now, your surgical risk is way high. You have a multi-level spinal stenosis. You're looking at a 3-level disc replacement or a 3-level fusion, and you're in your 80s, and you have mitral valve stenosis, and you have other comorbidities that put surgery at a high risk. Well, this is a very minimally invasive surgical option.
Or even just if you can't afford the downtime for having surgery, right? If you're a caregiver for somebody, or you have a job that you have to get back to, and you really have very minimal downtime with this procedure.
Yeah. And the really nice thing about it, if we think you're a candidate, you get to try it before you buy it. You get to take it for a test drive, just like a car. You get to actually take it home. You can drive it for a week. The battery, the wire sticks out your skin. We tape it to your skin, and then the battery pack is external, and that allows you to give it a try for a week. And if it really works well for you, we take those wires out for infection reasons, and we schedule it for a time where we can implant everything under the skin. Very similar to a pacemaker type implantation, battery pack under the skin, wires that go into the epidural space of the spine rather than the heart. In the case of a pacemaker, you're putting the wires in the heart. In the case of the spinal cord stimulator, we're putting them in the epidural space outside of those dorsal columns.
Yeah, this is the only thing I can think of in medicine where you actually get to try it before you commit to anything.
Seriously,
it's amazing, because you get to see, and you kind of just see here in the slide that we are looking for specific things, like how much of your pain is improved, how much is your activities of daily living improved. Like, can you walk further? Can you stand longer? Are you taking less pain medications? And one of the most overlooked things that people have with chronic pain is being able to sleep well. Yeah. So even if you get any relief with these aspects, then we call that a positive effect and a successful trial. And then that's the only time we would move forward with a permanent procedure.
And these spinal cord stimulators aren't isolated to the spine. There are other locations and other nerves that we can isolate. I know tonight's talk is very much designed around the spine, but there are things and nerves that can respond to nerve stimulation outside of the spinal cord as well. Things like the nerves that go to the SI joint, nerves that go to the knee, nerves that go to the hip. So there are a lot of applicable therapies for this technology. I think we talked a bit about the types of therapy. This combined paresthesia-free, which is when we really drive up the frequency of these. You don't have to feel any kind of sensation, or some people like paresthesia-based, where they feel a buzzing sensation, a vibratory sensation that masks and overrides their pain. And then some people like both, a little bit of paresthesia at times, paresthesia-free at times. I have patients. These programs, these clinical programmers are very skilled, and these devices have a lot of options for patients. I have patients who they just want one therapy, and it's the only therapy. It's either on or off. And I have patients that want 40 different therapies. They have their
Monday and Tuesday.
I'm going to get on airplane settings. I'm going to go out and go for a long walk settings, or I want to sit down and watch a movie setting,
Yeah.
or whatever it is. They have all their different settings, and the clinical programmers are extremely receptive to getting you the type of relief you need using this therapy. The first question that anytime a patient calls me who has a device says, hey, it's not working anymore, or I got a new pain, my first question is, did they call the programmer first, and have they tried to reprogram their device? Because that should be your first line of action once you have these, is to see if we can program a new program that's going to catch your pain and mask your pain.
Yeah. One of the devices too, the good thing about it is it can actually grow with you, right? As your pain evolves, or if your pain worsens, or your pain improves, or you develop other areas of pain, as long as you have this stimulator on there and it's working, they can program exactly how to block that pain, for what you need.
What about the batteries? Do they last forever?
So there's two options. You can have a permanent battery. A non-rechargeable battery. So essentially, it's a battery there. The lifespan is what, 10 years roughly? Yeah.
Depends on setting.
Yeah.
Yep.
But that one, it's kind of like a set it and forget it. You put it on there. You go home. You just turn it up. You can turn it down, change programming as much as you want to. When the time comes, when the battery needs to be replaced, we just open up that small incision, the little pocket that we made, and then we replace the battery. The other option that we have is something called rechargeable battery. So this battery, as the name implies, is something that you have to charge daily, kind of like how we charge your cell phone. This battery, because it's rechargeable, it could potentially last you your whole lifetime. So you just keep recharging it, and then you don't have to go back and fix it again. So, which is one of the really good advantages. It all depends on your tolerance for this type of stuff. Most of my older patients, they prefer the non-rechargeable one, so they'd rather just set it and forget it and not even worry about it. Some of more active younger patients, because they do a lot of different programming, they want to be able to kind of adjust the battery, kind of like do it yourself. It becomes a habit for them. So that works well. So it depends on, again, the options with the stimulators are endless if you take it as far as you want to.
The rechargeable, how do you charge something that's inside you? Well, it's the same idea as how you charge your phone when you just set it on those little circle devices that just transmits the energy through the skin. So you're able to take your recharger, you just place it on your skin, and depending on how drained your battery is, it recharges in anywhere from 1 to 4 hours. What's called recharging interval is what I use to gauge when we need to replace our battery. So if you're initially charging once a week, and then by the time it gets to, hey, my battery is only lasting every other day. So just like your cell phone, over time, your cell phone battery charge starts to lose duration, and depending on how long you're on it all day, but you might have to charge midday. Well, that's the time. That's my cue for, boy, it's time to go get a new phone. Same idea with these batteries oftentimes, and that procedure to open up the pocket where the battery is, pop the battery out, hook it up to disconnect the leads that are in there, put the new battery in, connect those leads, check it, make sure it works. It's a really quick and easy outpatient procedure.
And just like everything else right now, it has its own app. So it's it's legit when it has its own app. Anyway, so it's super easy to use. It's all smiley faces, and I think it's a nice add-on that they have on now.
How many more slides do we have to get through? I want to make sure we have enough time. Good. I want to make sure we have enough time for questions. I think we're kind of approaching our end report here, and we got some questions that came across. So if we could, let's turn it over. Okay.
Yeah, so we every patient that comes to our door, we do a full evaluation. So we look at your spine, we do a physical examination, we take a very thorough history. We look at imaging. If you don't have imaging, we order new imaging for you. So we spend a lot of time just being able to talk to the patients and seeing what we could do for them, try and find out what the diagnosis is and the symptoms, so we can come up with a treatment plan for you. So Dr. Nabby and I, we both spend an hour or sometimes even more with patients trying to get the whole story in order to get the right treatment plan for you. And as far as I could tell, most patients are good candidates for regenerative medicine. There's two things that we look at. One is how healthy the individual is. Usually the healthier you are, the better your cells are, the better your outcomes are, because your body's going to still be able to heal really well. The second thing that we look for is how severe is the injury. If we're talking about a very severe issue or more of an end stage type issue where you really do need surgery to address it, then we'll tell you that option. But for the most part, as long as you're not at that point yet and there's still a chance where we could help your back and help you avoid surgery, then we'll make that recommendation.
I think both Dr. Santan and I, and for those of you that couldn't hear the question was, I had a back injury from an accident, and I've been told I need surgery. Do you think regenerative medicine might be an option for me? And so along those lines, I think both Dr. Santan and I pride ourselves on the fact that we don't tell everybody we can fix you. We're honest. Like if we think you're a great candidate, we're going to be honest. We think you're a great candidate. If we don't think you're a great candidate, that doesn't mean we're going to refuse to do it for you. But because the downside of regenerative medicine is it doesn't work and you paid for it. That's the downside. I mean, the risks are extremely low. It's your own cells. We're very skilled with the needle. You know, we're not going to harpoon your nerve or damage your nerve in any way. We use X-ray and ultrasound, so we can not only see the targets we want to hit, we can see the stuff we want to avoid. We have infection mitigation strategies to decrease that risk of infection. So very, very low risk. So the downside is really, it doesn't work, and now I paid for it. Now I still need to go to surgery. So if we don't think you're a great candidate, we're going to be honest with you. And depending on how bad your surgical or your condition is that they told you need surgery, my guess is you have a fairly large disc herniation. There are patients that we do like a discectomy, even a minimally invasive discectomy, to really reduce the size of that disc herniation, and then put stem cells in there to regenerate it. So we take out the stuff that's been pushed out, and we put cells and biologics in that will help regenerate and stabilize the structure so that degenerative process doesn't continue. And hopefully we don't have these stories where, I had this level fused, and then 5 years later I have that level fused, and then I have this level fused, and that degenerative cascade that so many patients get unfortunately caught in.
Next question we got is the nerve block permanent? Does it wear off?
The question was, is a nerve block permanent or does it wear off?
It wears off. Like any medication, it's going to be temporary. So we usually use the nerve block primarily just as a diagnostic, again, to kind of confirm what our findings are.
And there are going to be people out there who say, I had a nerve block and my pain never came back. And that's because whatever the pain generator was, or the pain source that was causing it, when you block the nerve, it gave you that window to fix it. Whether that was fixed with physical therapy, whether it was with your body just fortunately healing itself on its own during that window. But nerve blocks aren't permanent. So it's nice when you do one and it fixes the problem and it's done. But that's the exception rather than the rule.
Yeah. Next question is, does regeneration work with arthritis?
Yep, that's probably the most common reason that we do regenerative medicine is for arthritis, because arthritis essentially is degeneration and wear and tear, right? So in hips, so most of the things that we treat for regenerative medicine is hips is a big one that we treat, knees, spines, shoulders, necks, and then you have your small joints like your ankles and your fingers and your wrists and stuff like that. But essentially, like any arthritis or arthritic joint will be able to treat with regenerative medicine.
Yeah, so it truly sounds almost too good to be true when we talk about it. We've been doing this well over 5 years now. I think in our 7th year we've been doing this, and I think I've finally stopped being surprised at how often it works, and how well it works. But what we're doing is using your body's natural ability to heal itself. So your body has an innate ability to regenerate. It's just, I think you alluded to earlier, that degenerative process wins out over the regenerative process naturally. And things like the right diet and the right exercises and avoiding certain activities. And there's a lot of things you can do naturally to get your body to hopefully stimulate and regenerate more. But eventually your degeneration is going to win out over your regeneration. We all get arthritis to a certain extent. And so what we do as regenerative medicine specialists is really harness that body's ability to regenerate itself by going to the source of where those cells are, whether it's the blood or the bone marrow or the fat, and isolating the cells that are in those stores, concentrating in a syringe, and then taking our interventional skills and saying, hey, body, go here. And you're able to get a huge push of cells to a very specific area to regrow a tissue that needs help. So whether that's tendon, ligament, cartilage, that's why it works for so many different things. It's just all those structures are made of different types of collagen, and we're just taking your body's cells that stimulate healing and growth of collagen, concentrating them and telling them exactly specifically where we want them to go.
A general question is there a list of the types of pain that therapy is good for?
So list the type of pain that this therapy is good for. It depends on the regenerative medicine therapy. Is that what you're talking about, or is it more the stimulation therapy? Anything that's for regenerative medicine, anything that's made of connective tissue, ligaments, tendons, bones, cartilage. Am I missing anything? Muscles. Yeah. All of those respond well to regenerative. Yeah. If it's the stimulator you're looking for, stuff that's more neuropathic pain, to a certain extent, all pain is neuropathic because all pain has to travel through a nerve to get to the brain. But things that come from joints can work, but not as well as things that truly are coming from nerves, like chronic nerve damage from neuropathy, diabetic neuropathy, spinal stenosis, and pinched nerves.
Yeah, or an abnormality in nerves, such as chronic regional pain syndrome, where the nerves are just transmitting, abnormal pain signals, even though it's not supposed to be transmitting pain signals. So anything related to a nerve contributing to your pain, which is, I would say most of how pain is, can be treated by a spinal cord stimulator.
Okay, I think we cleared most of the questions. We kept it under an hour, which is tough for the two of us to do when we start talking about helping people with pain. So hopefully you learned something tonight, and either Dr. Santa or myself, if you think you have something we could help you treat, feel free to call us, reach out to us. I believe our information is somewhere distributed in the emails that you received, but if not, it's Michigan Center for Regenerative Medicine is the name of our business. You can look us up online, regenerativemedicinemichigan.com, and our phone number is 248-216-1008. I think I got it right this time.
That's it. Yep.
Okay. All right.
All right.
More?
No, that's it. Good night. Thanks for hanging out with us, and good night.
Thanks, everyone.